Good afternoon or good morning, good evening, depending on where you are joining us from. And welcome to our webinar, Decline in Skills and Regression in Adolescents and Adults with Down Syndrome. All attendees are in listen-only mode. We will be doing a Q&A, and we ask that you submit questions using the Q&A button at the bottom. We won't be unmuting participants during the webinar. I will go ahead and introduce our presenter. We are very pleased to have our medical director, Dr. Brian Chicoine, who will be presenting today. And Brian Chicoine, MD, is the medical director of the Adult Down Syndrome Center in Park Ridge, Illinois. He is on the faculty of family medicine and Advocate Lutheran General Hospital. He received his medical degree from Loyola University of Chicago, Stritch School of Medicine, and completed his family medicine residency at Lutheran General Hospital. In 1992, Dr. Chicoine co-founded the Adult Down Syndrome Center, which has served and documented the health and psychosocial needs of over 6,000 adolescents and adults with Down syndrome since it opened. Dr. Chicoine has provided medical care for adults with intellectual disabilities for over 30 years and has presented and written extensively on caring for adults with Down syndrome. So thank you, Dr. Chicoine.
Thank you, Laura, and thank you everyone for joining us today. We look forward to being able to share some information on decline in skills and regression in adolescents and adults with Down syndrome. Just a quick introduction to our center. As Laura mentioned, we're in Park Ridge, Illinois, which is a Chicago suburb. We strive to serve adolescents and adults with Down syndrome of age 12 and up through a team approach, providing comprehensive, holistic, community-based healthcare services. And just as a reminder, this information is provided for educational purposes and is not intended to serve as a substitute for your own medical, psychiatric, mental health, behavioral evaluation, diagnosis, or treatment that you and or a person with Down syndrome is getting by a qualified healthcare professional. So let's just jump right in. We're going to try to define the decline in skills, and then we're going to describe some causes of decline in skills, including regression and Alzheimer's disease in adolescents, adults with Down syndrome. And we're going to identify some strategies to assist with diagnosis and treatment of decline in skills in individuals with Down syndrome. So let's all just start with the definition. What is decline in skills? So decline in skills, as we define it, is a decreased ability to perform or use previously mastered skills or abilities. So previously mastered is a key component of that definition. And that may include cognition, behavioral or psychological changes, ability to perform activities of daily living, motor function, and or speech, depending on the individual and the cause. So why might a person with Down syndrome decline? So in the younger children, autism is more common in people with Down syndrome than it is in people without Down syndrome. We won't talk about autism because that is typically onset is before the age that we see patients or see people with Down syndrome. Another cause is the Down syndrome regression disorder, and we'll talk extensively about that in a moment here. Alzheimer's disease in our older individuals with Down syndrome is one of the causes of decline. And then we'll just lump a lot of other things in other, and we'll talk more about that in just a moment. And we're going to start with the other. So let's just talk about COVID for a moment. Hard to have a presentation without some discussion about COVID, which has been so much part of our lives for the last 2.5 years or so. What has happened with regards to contributing to the decline in skills of some of our patients during the COVID pandemic? Nothing has really been unique about COVID, but the sort of the unique component about COVID is that so many things were happening simultaneously, and that included things like changes in routine. Many of us, including particularly perhaps people with Down syndrome, are routine oriented. And so that the change that occurred with the pandemic in routines, the loss of, or at least the temporary closing of schools or work or recreation activities, family activities, et cetera, certainly was a big change for people with Down syndrome and contributed significantly to some of the stressors that during the pandemic. Issues of grief and loss. Some of individuals with Down syndrome lost a family member who passed away from COVID. They had family members that they couldn't see for long stretches of times, depending on where they lived and the distance and whatnot. So that was another significant stress. Social isolation. We had lots of individuals that were either in their residential facility, not able to see their families, or they were in their own family home and not able to see other family members or friends that they would typically see through the course of their week or day or whatever. And then family and personal illness, family members that develop COVID, or individuals with Down syndrome develop COVID, and all the stresses of being ill with COVID and what that meant to individuals with Down syndrome. What we call the news overdose. It was just a constant bombardment of information about COVID that was on the news very continuously. And the people we see, the individual with Down syndrome we see, we're clearly absorbing that. They would tell me things in the office, news clips. They would talk about the virus or the other pandemic, and they clearly, individuals with Down syndrome were picking up and continue to pick up on these issues. There was changes in diet. People were living at home and they were not able to, not leaving the house like they had typically. And so now they were, like many of us, were eating much more throughout the day than they typically would have, or were using, comfort foods, if you will, to deal with the stresses that they were undergoing. There was family stresses, loss of jobs, temporary unemployment, family members trying to deal with supporting elderly relatives from a distance that they couldn't go see, and all sorts of stresses that families were experiencing during the pandemic. And then the lack of physical activity was another one. And many of our individuals with Down syndrome we see lost opportunities for exercise and recreation activities that they typically participated in, and so now they were trying to find new ways to be active, and some unfortunately had limited access. So again, none of these things are unique to the pandemic. We've seen people struggle with these throughout the many years that we've seen people with Down syndrome, but it's just the sheer volume of all these things happening simultaneously was pretty overwhelming for individuals. The other interesting thing that we're seeing particularly now is as the pandemic is changing and the world is opening back up, many of our individuals with Down syndrome have developed new routines at home with not participating in their previous activities, and now their new routine doesn't include those activities, and so now returning to what we might consider previously normal is a stress in and of itself, and that that's not the new normal is not being as active. And so now some of our folks some of the individuals we see are struggling with trying to return back to what would previously have been considered normal. So in addition to illness from COVID, there are many medical conditions and mental health conditions that can contribute to a change in function or decline in skills. And I could talk for hours on all these in detail about all these things, which I won't, but there's lots of health conditions, some of which are more common in people with Down syndrome, and some of which present differently in people with Down syndrome that can contribute to a decline in skills. And these slides will be available to you afterwards, but you can just see the breadth of potential issues to try to assess when someone has decline in skills, to try to see what the underlying health condition may be contributing to that problem. It includes heart disease, neuropsychiatric disorders, and certainly we'll talk about both Down syndrome regression disorder in a moment here, infectious diseases, sensory issues, loss of vision, loss of hearing, many physical health problems and mental health problems can contribute to a decline in skills. It can be adjustment to life events, transitions in relationships. And certainly we saw a lot of this during the pandemic, as I mentioned. But certainly, in Illinois, individuals with Down syndrome have school available to them up until age 22, typically, and then at age 22, school ends, and so that transition to new things can be very challenging, particularly if it's difficult to find things to do instead of as school ends. Loss of family, friends, pets, lots of grieving issues that can contribute to a decline in skills, work setting changes, physical relocation, being hospitalized, or again developing a medical condition, and then certainly COVID was a big one. And then autoimmune disorders, and we're still learning about this, and we'll talk a little bit more about this when I talk about Down syndrome regression disorder. But we know that individuals with Down syndrome have more challenges with autoimmune disorders from a wide variety of things, from thyroid problems to celiac disease and type 1 diabetes and many others. And then how might some of those also affect the brain, and how might some of those affect the mood and the psychological symptoms? So we'll talk a little bit about that, but we're still learning about that. So let's go next to Down syndrome regression disorder. Now, this is not a new description. It's a new name, but it's not a new description, or not a new condition. In 1946, a physician named Roland described what he called catatonic psychoses. And he described a number of individuals in I think he worked in an institution, if you will, at that time. But since then, it's been called a number of things: regression, adult regression syndrome, Down syndrome disintegrative disorder, and not 100% agreed upon, but more and more people are agreeing upon a Down syndrome regression disorder, which we'll call it here. We recently had a study published on the number of individuals with a variety of health conditions that we have seen in our healthcare system. And someone asked, why don't you have Down syndrome regression disorder in that? And part of the reason that there is not an official accepted name, and there's not an officially accepted code that goes along with, as other health conditions have, for Down syndrome regression disorder at this point. So there isn't I can't type in a specific code and come up with Down syndrome regression disorder. So we're all labeling it with codes that we have and are available to us, and then treating it as Down syndrome regression disorder. And again, this continues to be studied and discussed, and there's again a fair amount we don't know at this point, but have learned a tremendous amount in the last several years. Certainly from my perspective, having attended the Down syndrome medical interest group meetings for many years, this over the years would be something that we would talk. Occasionally someone would bring up a case of someone that had declined, and as we start to work through those, more and more people were starting to bring up cases. So I wouldn't say it's a common thing, but it's certainly much more recognized and much more commonly acknowledged than it was certainly in the past. And certainly in the last several years has gotten a lot more attention from both research as well as trying to provide assistance for individuals with Down syndrome that have this condition. Last month, there was a wonderful article published. Dr. Jonathan Santoro from California was the primary author, and he surveyed, if you will, 27 panelists who previously published on regression and Down syndrome or involved in national or international working groups. And he reached a consensus on the name, and so the Down syndrome regression disorder is a consensus, again, not an official diagnosis, but a consensus name, and also a diagnostic workup and diagnostic criteria. So when you get the slide, you can see more information on that in the link there. So what are the criteria that were basically agreed upon? One is that it's a new neurologic, psychiatric, or mixed symptoms over a period of less than 12 weeks in a previously healthy individual with Down syndrome. So it's pretty rapid onset over the course of 12 weeks or less, 12 weeks or less. And you really got to look at other causes. And again, we just went through a very lengthy list of other causes that you want to assess for and diagnose and or treat depending on the individual. And so the diagnostic criteria includes altered mental status or behavioral dysregulation. So there's often a behavioral component to this. There's typically a cognitive decline. There's a developmental regression with or without new autistic features. So it's not considered autism, but it can look like autism in some individuals. This is typically onset later in childhood, adolescence, or early adulthood versus autism, which is diagnosed typically in younger children. There's a new focal neurological deficits on exam and or seizures, sleep problems, insomnia, or circadian rhythm disturbance disruption is a common finding with the Down syndrome regression disorder. Very commonly, there are language deficits, impaired expressive language, sometimes impaired receptive language. There's often a movement disorder, not tics, but other movement challenges that are commonly seen with that. And we'll talk about catatonia here in a moment. And then there are frequently psychiatric symptoms that are part of this diagnosis. So catatonia is frequently a part of Down syndrome regression disorder, and it's an abnormality of movement and behavior. It can, but it may not be associated with a mental illness. Historically, it was thought that people with catatonia, had to have a psychosis or schizophrenia, and then later it was recognized that other mental illnesses could be associated with catatonia, and then later it's been recognized by some people that catatonia can occur without a mental illness. But again, the main issue is it's a movement, primarily movement disorder. So you might see repetitive or purposeless overactivity, or what we think more classically think of catatonia, it can also be resistant to movement. So it really can be excess or decreased movement. And in some ways, individuals can have a little bit of both, depending on, they might be constantly moving their hands, but when you ask them to move, it takes them very lengthy times to get up out of a chair, for example. So you can see a little bit of both in depending on the individual. There is what's called the Bush-Francis, that's two people's names, Bush and Francis, a catatonia rating scale, which is classically used to help diagnose catatonia. I do find that some individuals with Down syndrome who are perfectly healthy and normal and without catatonia or regression probably do have some of the few of the findings on the Bush-Francis catatonia scale, just based on the neurological impact of having Down syndrome. But certainly when the score is significantly elevated, it certainly speaks to the possibility of catatonia. So how is Down syndrome regression disorder different than the other forms of decline in skills? Is it a subcategory? Does it tend to be, we don't know for sure, but at this point, it does tend to be more severe and more pervasive than you might see with cause from something else. In some instances, you may see similar causes or at least similar contributing factors. So someone with, some other health condition that may be contributing to the decline in skills may be declining to this individual's decline in skills, but may actually also have more dramatic symptoms that would be more in line with Down syndrome regression disorder. So again, we're still learning, and hopefully more to come as time goes on here. So again, for an example, Joe, we'll make up a name. Joe has depression with a decline in skills. But over time, it becomes more apparent that his decline is much more pervasive and severe than we would typically see with someone with depression, and we see that there's a significant decline in skills that meets the definition of the criteria for Down syndrome regression disorder. And catatonia is frequently part of Down syndrome regression disorder, which is often not part of the decline seen with other health conditions. So again, Down syndrome regression disorder is commonly or typically seen in individuals with a Down syndrome in the early or mid-teens, early adolescence, sometimes younger, and then also and then up until typically mid-20s, but it can be a little older as well. And so that would certainly be different. Autism, which is sometimes this looks like it, and in fact has been called Down syndrome disintegrated disorder, which would suggest a connection to autism. previously thought. But again, autism in people with Down syndrome is diagnosed in childhood, although often diagnosed later in people with Down syndrome than it is in others. So early childhood, but not typically as late as teens or adolescents that we see with Down syndrome regression disorder. And then a third, or another cause, I should say, of decline in people with Down syndrome is Alzheimer's disease. And again, this is typically older, older than 40, typically would be the onset. Although I frequently get calls, someone will call and say, my son is 22, has been diagnosed with Alzheimer's disease. And I think that's exceedingly unlikely. And honestly, I've never seen anyone that young. And certainly Down syndrome regression disorder would much more likely be the diagnosis, although there may be many other causes for that need to be evaluated. So what is Alzheimer's disease? It's a progressive neurological condition, and it affects the brain. It really affects the whole nervous system, but primarily affects, we think of it as affecting the brain. It's a type of dementia. So people ask, what's the difference between dementia and Alzheimer's disease? The way I kind of think of it would be automobiles would be comparable to dementia. And so it's the broader category. And then Alzheimer's disease is one type of dementia, sort of like a Chevy or a Ford or a Mazda is one type of automobile. So dementia is the overriding category, and Alzheimer's disease is one of the types. And there are multiple types of conditions that can cause dementia. In Alzheimer's disease, typically what we see on the microscopic level in the brain cells looking at the brain under a microscope, would be see what are called plaques and tangles. And these are changes that are consistent with Alzheimer's disease. And they're also often referred to as neuropathological changes of Alzheimer's disease. We do know, unfortunately, that nearly all people with Down syndrome have these plaques and tangles, these neuropathological changes by the age of 40. But at this point, it appears that not everyone gets the symptoms of Alzheimer's disease. And so, why do not some people get Alzheimer's disease? And we don't know that either, unfortunately. We do know that Alzheimer's disease is thought to be uncommon before the age of 40 in people with Down syndrome, at least the symptoms. So most of the folks with Down syndrome have the changes in the brain at that point, but symptomatically, it has not become evident at that point. But we know that from the non-Down syndrome population as well, that people that develop Alzheimer's disease have been having changes in the brain going on for years, perhaps even decades, before they develop symptoms. And that's probably true for many people with Down syndrome as well. It's estimated, and again, strangely, although this Alzheimer's disease association with Down syndrome has been known for a long time, we still don't have really good studies that tell us exactly the incidence or the development of Alzheimer's disease by decade of life or by year, by age. But some data suggest that it's estimated to be about 55% in those between 50 and 59. Perhaps as high as 75% or even more in those 60 years of age or older. So it unfortunately is common as people get older. As you go back, how frequent is Down syndrome regression disorder? Certainly nowhere near this common. I don't know that we really know the answer to that. Is it 1 or 2%? Maybe. I don't think we really know for sure. But it certainly is much less frequent than Alzheimer's disease. So how is Alzheimer's disease similar to Down syndrome regression disorder? Both involve decline in skills. Both are probably neurological conditions that often have psychological symptoms. Both are challenging for the individuals and the families, and certainly, this is both of these can be very challenging for not the individual, but also the families. Both need more research, including ways to support the individual and the family. So certainly ongoing learning is very important with both of these conditions, unfortunately, or fortunately, depending on how you look at that. How is Alzheimer's disease different than Down syndrome regression disorder? So again, Down syndrome or Alzheimer's disease, age of onset of symptoms is typically more than 40. Unfortunately, it's not reversible. Down syndrome regression disorder, the age of onset is typically in the teens or the early 20s, sometimes younger, sometimes older, and sometimes can be reversible depending on what their contributing factors and what how the person responds to different treatments. We should really note, and this is very important, that not all decline in skills in either of these age ranges is Alzheimer's disease or Down syndrome regression disorder. So it's very important to make sure the individual gets a good evaluation to look for other contributing causes. And so you want to make sure that you're looking, is it the thyroid, the celiac disease, the sleep apnea, depression, et cetera, that might be contributing to the decline in skills, whether it's in an older person or someone in their teens. So how do we determine the cause of that decline? So you want to evaluate for contributing causes. Again, we went through briefly, but we went through lengthy lists of the things that you might consider as contributing factors. And you want to look on an ongoing basis for additional contributing causes. So, as symptoms change, I keep thinking, is there something else that may be contributing to this that was not found initially? Or have the symptoms changed such that it suggests that something new is contributing to this as well that wasn't there initially? I won't go into the detail of the medical and psychological workup, but we'll say we consider the list of conditions I shared earlier and more, and then we prioritize based on the history and physical and what we found, and then certainly as well as the frequency of possible causes in general, and more specifically the frequency of causes in people with Down syndrome. So we know that there are just some things that are more likely to occur in people with Down syndrome than they would in someone else, just based on the overall pattern of co-occurring conditions in people with Down syndrome. Just briefly, though, on the diagnostic workbook, a good history and physical is the starting place. There may be a role depending on the symptoms and the workup for neuroimaging, which might be a CT scan or an MRI of the brain. Blood work is very likely indicated. Again, depending on the condition and the symptoms, lumbar puncture, a spinal tap. Certainly in the Down syndrome regression disorder, in the article I shared a moment ago, an MRI and blood work and a lumbar puncture and an EEG, the brainwave test, are all recommended. And there may be certain urine studies that are indicated, and then other testing based on what is found on the history and physical exam. And how is a decline in skills treated? So we want to treat, of course, we want to treat the diagnosable conditions. So if the person has hypothyroidism and underactive thyroid, treating them with appropriate replacement therapy, thyroid medication, for example. Catatonia has certain medications or other ways that can be treated, including ECT. If there's autoimmune encephalopathy, which is, we talked a little bit before about autoimmune diseases affecting the brain. There are now treatments available that we can consider for that. Sleep apnea is significantly more common in people with Down syndrome and can cause a decline in skills. And so we want to consider treating that. So there's many things that we might want to consider treating that may be either the primary cause or a contributing cause to the decline in skills. Want to treat related signs and symptoms. Sometimes there are behavioral or psychological symptoms that are part of the psychological diagnosis that are part of the presentation of the symptoms that need to be addressed with medications or other ways to treat them. And we want to use therapies to help improve function. So, certainly if someone has lost skills, lost their speech as part of the treatment, speech therapy might be appropriate. Or if they've lost the ability to do activities of daily living as you're treating the underlying causes, perhaps occupational therapy or physical therapy might be indicated, depending on the individual. So lots of ways to address not only the underlying problems, but also the resulting symptoms and or the resulting declines that are part of the presentation. I often say we have to start with, in addition, I have to start with what I call safe activities. So a number of these individuals that decline for a variety of reasons, become to sort of not wanting to leave the home, not wanting to participate in activities, and there does seem to be a real fear factor in that. So reintroducing people into activities, what I call safely, meaning if we try to go too far, too fast, it can be frightening and cause people to shut down again and not want to participate. So again, trying to follow their lead and reintroducing them with encouragement, but not forcing them into things that are too stressful for them, that will cause them to sort of back off significantly again. So that can be a very challenging thing to do. And people say, well, how much is too much and how much is not enough? And there isn't one answer fits all. In fact, it's very individualized. And so, families end up really probably knowing more how much to encourage than I can tell them, because they're watching and seeing how the individuals are responding, and then responding in kind to try to encourage them to more activities. Want to treat the associated symptoms, and that may be depression or anxiety or agitation or sleep challenges. And the medication choices are influenced by the individual's particular symptoms and the particular effects and side effects of the medication. Observation and report of symptoms are key to assisting with medication selection. So certainly your role, family's role as observers, and then the reporter of information for many of our individuals with Down syndrome. We may struggle with providing the symptom report themselves. So families and other friends and caregivers are very important in helping the provider to appropriately treat these associated symptoms. And it might be, just for example, in somebody with depression with decreased appetite and decreased sleep, there's an antidepressant called mirtazapine, which is an antidepressant, but it also seems to stimulate appetite and help people sleep. So that might be a good choice, a good one in that choice. In someone on the opposite who has increased appetite, the medication bupropion or Wellbutrin, which is a medication for depression that in some cases decreases appetite, might be appropriate. In somebody that is having pain as part of it, arthritic pain or other, for example, duloxetine is an antidepressant that and a medication for anxiety that helps with that type of pain. So again, picking the medication will certainly depend on the individual's symptoms. And then again, for agitation, it might be a seizure, an anti-seizure med that is appropriate in that individual. So the medications. Certainly a wide variety of medications depending on the individual's need and symptoms. I should mention that there is some genetic testing that's now available. It doesn't tell us what medication to use for psychological diagnoses, but it does give you an idea on how individuals metabolize these medications. So, for example, a medication that this individual metabolizes very rapidly may not be appropriate because you never can really get a good level because his or her body breaks it down very rapidly. Conversely, a medication that the individual doesn't break down very well at all, very small doses, may cause symptoms because the body is not breaking the medication down. So, again, doesn't really tell you what medication to use, and exactly how much benefit those are at this point is not known, but it can be one more arrow in the quiver, if you will, to try to help pick correctly the medications that are being recommended. How about medications for Alzheimer's disease? Unfortunately, studies really have not demonstrated that the medications that are presently approved for Alzheimer's disease really are effective in people with Down syndrome who develop Alzheimer's disease. There are several medications available. There's one category called cholinesterase inhibitors. For example, the Mepazil or the Aricept is one, and there's several, rivastigmine, galantamine, and others. We typically have not felt that these have been that beneficial. They can contribute to decreased appetite or weight loss, and there's even potentially a side effect of seizures, although seizures are common in Alzheimer's disease in people with Down syndrome, so it's hard to tell sometimes whether it's the medication or just the progression of the disease. And similarly, memantine, which is a different category, it's what's in the NMDA receptor antagonist. There's just one in that category at this point, the memantine or Namenda. And probably the most common side effect we've seen with that one, unfortunately, when I was still prescribing it, was agitation, but also constipation or diarrhea or confusion or dizziness or drowsiness. So again, I personally tend not to prescribe these, as I've not personally found them to be beneficial and to have lots of side effects. You may have been aware in the last year or so that this aducanumab was approved for Alzheimer's disease. A lot of discussion about whether that should be used in people with Down syndrome. And our approach is similar to the organizations listed there, is that we certainly need to include people with Down syndrome in these studies, that they were not included in really in any of these studies, but particularly this new one, because there are some potential for some of the side effects of the aducanumab that people with Down syndrome may be more susceptible to, which could actually reduce the effectiveness. So at this point, most organizations and most providers that I'm aware of are not recommending this for people with Down syndrome. But certainly more study is needed. And hopefully there will be more medications coming down the pipeline in the not too distant future that will be studied in people with Down syndrome and give us more information. Certainly there's a lot of push for that in with the federal government to try to encourage including people with Down syndrome in these studies. As far as treatments for Down syndrome regression disorder, certainly there's a wide variety of medications depending on what the underlying cause is or the other underlying contributing conditions are, and what the symptoms are. For those with catatonia, electroconvulsive therapy can be very effective. And again, the therapies like physical therapy, occupational therapy, and speech therapy can be very effective in helping people regain some of those skills. Counseling in the appropriate situation can be very helpful, in a sense, both for the individual and for the family, to try to help them overcome how this has affected not only the individual, but the family. And then there's been much more in the last couple of years on looking at immunotherapy. Presently, the IVIG, the immunoglobulin therapy, is really being looked at. And again, Dr. Santoro has written a few articles on this and looking at how that may be an effective treatment in some individuals with Down syndrome regression disorder. So hopefully more to come on that in the not too distant future. So how can families support an individual with Down syndrome who has a decline? So starting with helping with the diagnosis and treatment. So first thing is being observant, as families typically are, and sharing your observations. I say that for many of our folks with Down syndrome, no matter what the contributing cause, that they can oftentimes they can contribute some to the description of symptoms, but oftentimes they may need some assistance with describing the symptoms. And when there's a decline in skills, they much more typically will need some assistance with describing the symptoms. And so what I call secondhand report, not the individual themselves reporting, is always has the potential to either misperceive something or not see something or see something a little differently than what's really happening. So secondary observations or secondary reports are have the potential to have some challenges to them to start with. So very important to be as observant as possible, and then share your observations, write them down if necessary. Look at mood, behavior, function, motor activities, sleep, appetite, and any other symptoms you notice. Very important to share with the treating provider. And one of the questions I ask when I'm seeing somebody with a regression, Down syndrome regression disorder, for example, as we're treating, what is still missing from the person? What did they have before this start? What skill did they have, or what behavior did they not have, or what behavior did they have, or whatever that is not there now, that is still missing. And so continue to share your observations on an ongoing basis as not only the condition progresses over time, but as the individual is being treated. And so the motor activities, for example, you're looking at tremors or muscle rigidity, or what people will frequently describe as being frozen, or sometimes in the exact opposite I mentioned before, it'll be very persistent movement. So lack of movement or persistent movement, both can be depending on the individual. How does it present? When it presents, I'm sorry about that. When it initially presents, sometimes oftentimes the focus may be on some of the behavioral challenges. So if there's an aggressive behavior, for example, that may be the thing that's causing the most dysfunction in the person's home or environment. And so sometimes the other symptoms are not not as well noted and not shared based on what how that's affecting everyone around the individual. So again, on an ongoing basis, continue to observe and report as not only other symptoms become more evident or other symptoms actually develop. And so it's very important to continue to share that with the provider. Again, the role of families and others involved in a person with Down syndrome life, helping the person regain function, I talked about the safe activities, reteaching, sometimes some of the skills lost just don't come back after treatment. The person has to kind of relearn them as well. So they're not only maybe a treatment for the underlying condition, but also something that has to be retaught that the person has lost and needs to regain with assistance. And then I always tell families, trust yourself, what you're seeing and what you're struggling with, trust yourself and share that so that the provider can have a better sense of what's going on. There's other non-medicinal strategies that you might participate in. Sensory strategies, for example, maybe things that, if the person has developed a sensory, kind of a sensory challenge or being overly sensitive to the sensory stimulation in the environment, that may be something that can be diagnosed and the families can participate, or others in the person's life can participate in the treatment. Creating schedules and routines. We do know that folks with Down syndrome, as I mentioned earlier, tend to be, many of them, not all of them, but many of them tend to be routine oriented. And so trying to create new schedules and new routines, including, visual schedules or visual aids that may be important. We also know that people with Down syndrome tend to be visual learners. And so using visual aids of some form may be very helpful to help get the person back to where they were. And then, this may be around issues of sleep or healthy eating or physical activity. So anything you can do to try to get individuals back on track can be very helpful. And then again, encourage safe social interactions. Again, trying to go too far, too fast can actually cause the person to go one step forward and 3 steps back. And so really trying to work with the individual to help them continue to move forward and back into their previous life or more normal activities is very important. So I just want to talk just present a couple of cases, and then I want to leave some time for questions. So real briefly, so we'll talk about a 22-year-old woman with Down syndrome who presented with a personality change, difficulty performing at her job, inability to care for herself or learn new skills, and had agitated behavior initially and followed by a decreased movement, eating, and interest in activities. And this was progressive over 6 months. This case goes back a number of, all these cases are sort of conglomeration of cases, but this, think of this one as something that occurred a number of years ago. So we weren't calling that as I'm thinking back to some of our earlier cases, we weren't calling it Down syndrome regression disorder at that time, but that's what I would now call it now. And she was treated with medication and had some improvement, but really she got electroconvulsive therapy and had a dramatic change and dramatic improvement and returned back to her baseline. And then again, with the family's assistance, she had a measured reintroduction into activities and used a lot of visuals of her daily schedule to get her active again in both previous and new activities that she was interested in. 27-year-old man with Down syndrome presented with reduced interest in activities. He was apathetic. He had altered sleep, and he had become generally disagreeable, which really was a significant change for him. He did not have a full-blown regression syndrome, certainly, or disorder. But as we looked through his situation, he had been started on a medication, dicyclamine or Bentyl, for irritable bowel in the month or two prior to all the onset. And so, again, medication side effects is something to really think about as a potentially contributing factor to individuals that have a change like this. And so his primary treatment was we stopped his medication, and again, helped him return to safe activities and using the family using visuals with him to to get him back into his previous routines. 32-year-old man with Down syndrome presented with depressed mood, loss of skills, and hallucinatory behavior. So he was seeing things and talking to people that weren't there. Concerned that he had developed psychoses. There was certainly, when he came to us, the spoken concern was that he was developing Alzheimer's disease. Again, was there a concern about the possibility of Down syndrome regression disorder, perhaps presenting a little later than we would typically think of? This gentleman underwent again, he did not have all the symptoms of Down syndrome regression disorder, but he underwent a sleep study and had significant sleep apnea. And so his treatment was CPAP, the continual positive air pressure device that is often used for sleep apnea. And his symptoms all went away and he returned back to baseline. So sleep apnea can be a very significant contributing cause of this. He did not have any of the movement disorders commonly seen, or movement dysfunction commonly seen with Down syndrome regression disorder. Another case is a 22-year-old woman with Down syndrome who presented with depressed mood and catatonia. And so as we evaluated her, again, we diagnosed the Down syndrome regression disorder with depression and catatonia. We treated her with an antidepressant, but she had no improvement for the depression, and that medication was stopped. And then the catatonia initially was not as clear, but that became more clear. And we started on lorazepam or Ativan, which is one of the treatments for catatonia. And this case predates the focus now on looking at the potential for autoimmune encephalopathy, which Dr. Santoro has talked extensively about, and I mentioned it a bit ago. But again, she was started on lorazepam and had significant improvement in the catatonia, but still seemed to have depressive symptoms. And then we restarted or started a different antidepressant. And this time the antidepressant worked very well. And so it seems, and I've seen a number of individuals similar to this, in which until the catatonia is improving, sometimes the depression will not respond as well to the antidepressant. So in this case, as in several others, improving the catatonia, whether it be with lorazepam or ECT or whatever, sometimes then the antidepressant will be more effective. So we certainly know that this is, particularly those with Down syndrome regression disorder, that this can be a very challenging thing, both for the individual and for the family. So some things that you might do to consider finding support. There is a Facebook support group for Down syndrome regression disorder and regression in Down syndrome. It's a closed group for families and caregivers who support individuals with Down syndrome who have experienced or are experiencing regression. So it's not open to anyone that does not have, is not assisting a person with Down syndrome with regression. So when you get these slides, if you click on that, you will be asked what your interest in participating in that Facebook group is. That Facebook group is going to be very helpful to families to not only share common challenges and how people are dealing with it, but also to get guidance on where to get care locally to support the individual with Down syndrome and the family. There's information on again, when you get the slides, you can click on that link, and there's information on finding a Down syndrome clinic or healthcare providers. And then I would encourage, if you have a local provider who perhaps is not as knowledgeable about Down syndrome regression disorder or other issues with Down syndrome, would be to consider joining the Down syndrome medical interest group, and the link is there. It's a group of providers, professionals who are serving the medical needs of in a variety of disciplines, physicians, therapists, counselors, psychologists, et cetera, that are serving people with Down syndrome and sharing information. We often talk about challenging cases and including, obviously all de-identified, so the individuals you don't know who the person you're talking about is, but and trying to support each other and trying to help find the appropriate treatment for those individuals. again, that would not be for the families, but for individual, for your provider would be welcome to join the Down syndrome medical interest group. On our website, we have our resource library. We have a number of resources on decline in skills and regression, as well as information on Alzheimer's disease and dementia. And these are the links to the resources, and we also have a Facebook page that we share information regularly on a wide variety of health issues for people with Down syndrome. So I'm going to pause. When you get the slides, you'll see there's a number of slides of references too, if you wanted to look into some of this information further. But I'm going to stop and turn back to Laura for looking at some of the questions.
Thank you so much, Dr. Chicoine. We have received so many questions. Thank you for submitting them both through the registration process as well as now during the webinar. We're going to try to answer as many as we can, but we may not be able to get to all of them. So we do encourage you to look at the resources linked in these slides, as well as the other resources in our resource library. One of the questions we received is, can decline in skills or regression be prevented?
Yeah, that's a good question. Specifically Down syndrome regression disorder, we don't know. I think what I would say is that, if you look at, there's a lot of health issues that can contribute. So really optimizing health. So I would recommend, starting with healthy eating. I was just looking at an article this week on this wasn't done in folks with Down syndrome, but just in general on the processed foods and the onset of anxiety and depressive symptoms, for example. Good sleep, regular exercise. We know all those things, what we can do to try to keep physically healthy can contribute to mental and may contribute to cognitive health as well. So that would be the good, first place would be the healthy eating, regular exercise, good sleep, and certainly health screening, looking at with your provider, the Down syndrome healthcare guidelines, both for children and adults, looking at those. What are some of the underlying health conditions that tend to be more common in people with Down syndrome that we'd like to find early and treat them? So any of those things would be a starting place. Real specific information on preventing it, we don't have at this point, but I think those are good starting places to really try to prevent these problems down the road.
Thank you. Can you share more information about ECT? What are some of the side effects? And then also, how many ECT treatments is too many if maintenance ECT is necessary?
So that's really a good question. So ECT, the electroconvulsive therapy, is we all have sort of, many of us have pictures in our mind of old movies that, made that look like a very scary thing. Now it's done in a very controlled manner. It's generally people are under sedation or even anesthesia typically, and in our place it's anesthesia, and then electrical therapy is given to the brain, and it causes a seizure, and exactly how it works is not clear, but can be very effective in catatonia and persistent depression, for example. And we've seen some dramatic improvement in some of our folks with regression and catatonia, and even some folks that have had it for many years before they got the ECT. The one thing that's different about catatonia in people with Down syndrome than the rest of the population is that oftentimes an initial round of ECT, often 12 or so, twice a week, for example, is often the way it's done here. And then many people with Down syndrome will require that it be done on an ongoing basis, usually not that frequently. It might be done once a week for a while, and then every other week. Some of our folks are getting it once a month on an ongoing basis. So the challenge with the ECT for catatonia people with Down syndrome is that it does, in some individuals, does require ongoing treatment. Not all, but some. How many is too many? I don't know that we know that. And we've had some people been getting it for quite some time and for years and seem to be continue to do well with it. There is some concern about memory impairment, although we've not seen, we certainly see some people right after they get it have some memory impairment, but I am not really aware of any of our individuals that we have taken care of or take care of that have had persistent memory impairment after ECT. There is some discussion that, perhaps there's something a little different about catatonia in people with Down syndrome compared to others because of this ongoing need for maintenance therapy, if you will, to prevent recurrence.
Thank you. Can an individual with Down syndrome and decline in skills improve without medication assistance or other assistance like SSRIs, IVIG, ECT, etc.?
Yeah, there are some people that will ultimately get better. And, I think, again, trying to do all the other things, the healthy eating, the regular exercise, the activities, all those things, some people will get better. But I think, unfortunately, a lot of folks do need some treatment to get better at all, or certainly better in a more timely fashion.
Thank you. Is there a link between COVID-19 infection and decline in skills?
Yeah, that is a great question. I don't know the answer to that. I don't know that anybody does. I think for example, we're still learning about, long COVID or persistent COVID, whatever you want to call it, in the non-Down syndrome population. And I think we really know very little about it in people with Down syndrome. Certainly the pandemic has been a very big contributor to the stress of the pandemic has been a big contributor to people declining in skills. I've certainly seen that in people that actually had COVID infection and those that did not have COVID infection. So whether, how much of that is the virus, how much of that is the stress of the pandemic, I don't know that we can say that at this point, but I guess I would not be surprised if the COVID infection, certainly other people talk about having sort of a cloudy sensation or, feeling different cognitively after having had COVID infection. If that in fact occurred in people with Down syndrome, I don't think that would be surprising, but I just don't know that we have a real sense of that at this point.
Thank you. How can you determine if a young adult or teen is experiencing regression or decline in skills or going through typical changes associated with puberty?
Yeah, that's a good question. So, I think that, often families will, again, not even around regression, but we'll be talking about changes in behavior and whatnot. And I'll often ask, as they're describing their teen with Down syndrome who is talking on the phone all the time and only wants to spend time in the room and doesn't want to hang around with his parents, and as his room that was previously neat is now a mess and things like that. And my first question typically will be, have you had other children that were once teenagers? And so folks with Down syndrome certainly have the capability, if you will, of demonstrating teenager-like behavior. But certainly the difference in regression will be, certainly from a magnitude standpoint, it is much more than just those things. It is a true loss of skills. It is often loss of speech, the motor dysfunction. So it is, while Down syndrome teenagerism certainly can be an issue, regression is many magnitudes more challenging.
Thank you. You mentioned that genetic testing to look at how medications are metabolized might be an option. Where can you get that testing, and is there a certain company that you recommend?
Well, I try not to recommend a company. Though I mean, if you want to reach out to us, I can tell you what company we use. I don't know that I want to, just share that broadly, but there are some companies that do that, and we just one that we've connected to, and we so we've signed up with them. We have a connection to their website, if you will, that we sign in and we enter patient information and collect the sample. And it's ours is a swab on the inside of the cheek, and then send that to the company, and then they do the genetic testing. So your provider would typically be the one that would be able to share that, but they do have to sign up with whatever company it is that ultimately they're going to use to be able to send those tests in.
Thank you. When do you decide to change medications or treatment approaches?
Good question. So, the adage that many will talk about in people with Down syndrome is start low and go slow, meaning, we'll start with lower doses, because many people with Down syndrome will respond to lower doses and will actually have side effects to higher doses of the psychotropic medications. So, start low and work our way up slowly, and depending on the symptoms and how they're responding. It really is depending on how they're responding, how they're not responding, what side effects they do or do not have that contribute to changes. So some people, you start on a low dose and they get abruptly worse. Is that the condition, or is that the medication? Not always not always easy to tell which is which, but if we think that it might be the medication, that we might be switching that person out very early on in the course. If we start a person on a low dose and they get very sedated, and we say, let's give it a week or two and see if they get, that goes away, which it often does. But in this individual, it doesn't. So again, that might be someone that we're switching off quickly. Others, over time, we've worked our way up. We got a certain amount of benefit, and then we're no longer getting benefit, so we probably will stop raising the dose at that point, and then we might either, depending on what the situation is, either consider starting a different medication or adding an additional medication. Again, so very individualized. I don't want to skirt the question, but it's hard to give a generality because each individual is different.
Thank you. We're going to continue to answer questions for about another 10 minutes. And if you have to drop off, we will be sending the recording out via email. We've received many questions, both from people here in the United States and people from other countries, about finding providers who are knowledgeable about Down syndrome regression disorder and other declines in skill, as well as how to share information with them. I know you talked a bit about this, but would you mind repeating and expanding on that?
So absolutely. So the first thing, that there are a couple sites, the Global Down Syndrome Foundation, and I think is it NDSS or NDSC? I can never remember which one has a list of clinics, and I think we shared a link with that. And so that would be one place to start. I would start with your local provider and see what they can provide. I would certainly talk to the parent groups and other family support groups that are available in the area, and see what they've been able to, what they've, who they've used for this situation. I would look at that Facebook page. I think that's very important. The person who started that Facebook page, I'm not revealing anything she hasn't revealed herself, is a physician who also has a daughter with regression, and so that Facebook page is very, very helpful to lots of people. So those are ways. I would encourage your provider to check in with the Down Syndrome Medical Interest Group. We are the Down Syndrome Medical Interest Group is working on a number of ways to support providers to provide services for people with Down syndrome, and obviously this issue of Down syndrome regression disorder is right at the top of the list of ways we're trying to get more information out. So I'd encourage your provider to take a look at that. And then there's a number of things that are not come to fruition yet, so we're still working on, but hopefully we're going to be able to provide significantly more assistance to providers going forward to care for these individuals that are challenged by these changes.
Thank you. Um, One question was, my loved one with Down syndrome is 36 and has started to slow down in the last year. She's more tired and forgetful and has some trouble concentrating. Is this all part of the normal earlier aging process of adults with Down syndrome, or potentially something else?
So we know that folks with Down syndrome do tend to have earlier aging than others. And so as people get out in their 40s and 50s, we begin to think of them as perhaps 5, 10, 6, even as they get out in their 50s and 60s, even 15 or 20 years beyond, if you will, their chronological age. That said, we all know older people that don't have Down syndrome, and those that do have Down syndrome, that are very functional and very active and do lots of things, even in folks without Down syndrome as they get 70s, 80s, 90s. And saw a mom here yesterday that was 100. So we do see active folks. It doesn't mean that some people won't have some challenges, but many don't. So I always err on the side of not assuming that this is just aging, and go looking for other potential causes. So, again, slowing down and fatigue, is it hypothyroidism, underactive thyroid? Is it sleep apnea? Does the individual have heart complications? Celiac disease, many things that are more common in people with Down syndrome that could contribute to that. So while it could be earlier aging, my recommendation is not to accept that until it's really been evaluated.
Thank you. What health professionals would you say are vital for the care team of an individual with Down syndrome regression disorder?
I think it varies with what the local resources are and what who in your area has developed interest in this. So I think it's always good to have I'm a primary care provider. I have the bias. I think it's a good primary care provider because you really want to be looking at other health conditions. You want to optimize health on a day in and day out basis. So I think a good primary care provider. But again, then depending on what the symptoms are and what the issues are, there may be a neurologist involved. There may be a psychiatrist involved. Again, occupational, physical, speech therapies. Again, and then depending on the other symptoms, there may be other professionals involved. So I don't think one size fits all, but I think certainly what we're knowing now is working on developing ways to evaluate for this autoimmune encephalopathy that is Dr. Santo has talked so much about recently, but also looking at all the other potentially contributing health conditions, and then someone that's able to manage, again, because of the psychiatric symptoms are so common, able to help manage some of those symptoms is very important. In our case, we're still working with improving or expanding our contribution of neurology in our patients who were looking at the autoimmune encephalopathy situation. We're very fortunate that we have a psychiatrist who's skilled in and willing to provide ECT when appropriate in our patients. So, it just kind of depends on your situation and what might be necessary and helpful.
Thank you. We've received some questions about Alzheimer's disease, why it's more common in people with Down syndrome, and can people with Down syndrome get other forms of dementia? And are there tests you recommend for screening for or determining the severity of Alzheimer's disease?
Good question. So people with Down syndrome can get other causes of dementia, although it is thought that Alzheimer's is it just is in the rest of the population the most common one. And it is thought that people with Down syndrome have more Alzheimer's disease because of the presence of certain genes associated with Alzheimer's disease on the 21st chromosome. And so because people with Down syndrome have an extra 21st chromosome, they have, if you will, more of a genetic burden that's associated with developing Alzheimer's disease, and the gene of concern is the APP gene, is what it's called. Others are looking at, are there inflammatory issues that may be contributing to Alzheimer's disease, and people with Down syndrome more frequently. We do know that autoimmune conditions are more common, and what contribution of autoimmune and resulting in inflammation may contribute to Alzheimer's disease. So there's certain metabolic concerns that seem to be more common in people with Down syndrome. That what is that contribution? So I would say that the general sense over time has been that this APP gene on the 21st chromosome is the primary issue, but there are others starting to look at other possible contributing causes. Certainly working people up, again, similarly, working people up for contributing causes. Imaging of the brain can find atrophy, although some people with a shrinkage of the brain, although some people with Alzheimer's disease don't have atrophy. So oftentimes the CT or MRI is not overly helpful in what it does show. Sometimes it may show something else that is contributing to the decline, although often it does not. And then the other issue is if one's going to do an MRI of the brain and the person needs anesthesia, we find that many people with Down syndrome and Alzheimer's disease respond poorly to anesthesia. So they develop more cognitive impairment. So trying to decide the benefit of getting imaging of the brain versus what potential complications it may have is one of the discussions we have. I think there's an additional part of that question I'm missing there, Laura.
Tests to screen for, or
Oh, right. So there is a real nice the National Task Group on Dementia and People with Intellectual Disabilities has a real nice, it's about a 6 or 7 page questionnaire. If you just I don't know if we have a link in there, but if you Google NTG, National Task Group, Down Syndrome, Alzheimer's Disease, it's pretty easy to find their webpage. And they have a very nice screening tool that they recommend. It's lengthy. What I've done in my practice, I've taken there's I think I forget it's 6 or 7 area sort of highlighted areas that they look at. So I've sort of taken those 6 or 7 highlighted areas and built certain questions into my questionnaire that I ask each patient annually to get some sense of that. It's not, I don't have a 6 or 7 page document on my chart. I don't have time for that with each patient, but you try to get some sense of decline in a variety of areas that might be hallmarks of Alzheimer's disease: memory, gait changes, personality changes, behavior changes, etc. The things to look for. So real nice screening tool. What the Down syndrome the global Down syndrome healthcare guidelines that came out a year or two ago recommend is at least by age 40 screening each individual with Down syndrome annually in those 6 or 7 areas to start to look for decline.
Thank you so much. This will be our last question. We've received some questions about individuals with Down syndrome who take a long time to do certain parts of their routine, like getting dressed or eating breakfast. Would you mind commenting on that?
Yeah, so so a slowness to the pace of activities is not uncommon in people with Down syndrome, many of them throughout their life. So that in and of itself, if that's who the person is and always has been, that's something to just have to kind of work around, and visual aids and others may be helpful to try to speed things up a little bit. There's a thing called self-modeling, where you take a video of a person doing something at a more appropriate, take a video of them doing the activity and then kind of splicing it together to make it, to speed it up and show that to the individual. And that sometimes that helps people move more quickly. So that's the one piece. The other piece is if the person was doing something at a more normal pace, if the question is, but doing something at a more normal pace and then changes and then is moving very slowly. For years that we've been calling that obsessional slowness. And I saw an article where there's really kind of an obsession about moving very slowly. And there was an article a couple of years ago in the non-Down syndrome population that questioned whether that's even a diagnosis. I don't see other people without Down syndrome, so I can't speak to that, but it is clearly something we have seen in people with Down syndrome over the years. As I've been thinking about this again in the last several years, is obsessional slowness related to Down syndrome regression disorder? I would say for most of our folks that have had this obsessional slowness over the years, I would say the big difference between that and Down syndrome regression disorder, although both of them will often move slowly, is that people with obsessional slowness haven't lost skills. They're still able to do those things. They just do things very slowly, which would be a typical thing. Don't typically have other movement issues. Don't typically respond to the treatments that, or often don't respond to the treatments that we would typically give for Down syndrome regression disorder. So does seem to be not a common thing, but we have seen a handful of people over the years have I think what you're referring to, perhaps.
Thank you so much, Dr. Chicoine, and thank you to all of our attendees. We hope you have a great rest of your day.
Thank you.